Hi friends, today I will talk about resistant hypertension and new advances in management of resistant hypertension. First, the disclaimer. This Caring Docs YouTube channel does not provide medical advice, and information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any personal or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. As we know that high blood pressure is a major cause of heart diseases, heart attack, stroke and kidney failure. Resistant hypertension means blood pressure stays above the target despite using three different types of medicines, including a diuretic, at the best tolerated doses. If the BP is controlled only after adding a fourth or more medicine, it is called controlled resistant hypertension. So, we can define the resistant hypertension as BP of hypertensive patient that remains elevated above goal despite the concurrent use of three antihypertensive agents of different classes, commonly long-acting calcium channel blocker, a blocker of the renin-angiotensin system, or uh, angiotensin receptor blocker, and third drug diuretic. And diuretic should be there. All agents should be administered at maximum or maximally tolerated doses and at the appropriate dosing frequency. How do we approach resistant hypertension? Many patients who seem resistant, they are actually not suffering from resistant hypertension. High BP can remain because of other factors also, and for them we call it as a pseudo resistance. About 50% of the resistant hypertension cases are pseudo resistant hypertension, and before diagnosing a resistant hypertension, the American Heart Association and European Society of Cardiology recommends ambulatory blood pressure monitoring or frequent home BP checks to rule out white coat hypertension, where clinical readings are high but home readings are normal. The causes of pseudo resistance are wrong BP measurement techniques, white coat hypertension, under treatment or clinical inertia, patient not taking medicine regularly. As we know that causes of secondary hypertension are maybe because of kidney disease, renal artery stenosis, some hormonal imbalances leading because of primary hyperaldosteronism, Cushing syndrome, pheochromocytoma, thyroid, parathyroid disorders, acromegaly, other causes like sleep apnea, certain drugs, coarctation of aorta, pregnancy related causes. Before labeling a resistant hypertension, we should rule out these causes. So, the resistant hypertension affects 2 to 40% of the treated hypertensives. About 40% of the patients of apparent resistant hypertension is due to white coat effect or poor adherence. It is twice as common in chronic kidney disease. The current therapies for resistant hypertensions are lifestyle measures. We should always adopt lifestyle measure as the first step. We should encourage the patient to reduce the weight. He should be encouraged to take low salt diet rich in fruits, vegetable with low fat. He should quit smoking. He should limit the alcohol and caffeine intake. He should be encouraged to do regular exercises and should have good sleep. He should reduce the stress and avoid excess cold or air pollution. And this, it has been seen that lifestyle measures, they lower the systolic blood pressure by 20 to 25 55 mm of mercury. Uh, After the lifestyle, we should put the patient on pharmacotherapy It was initially thought that taking medicine at night reduces the blood pressure nicely, but there are some studies which show that irrespective of the intake of medicine at any time of the day, there is no much difference in reduction of blood pressure. So we have a standard drug regime. We should start with three drugs like ACE inhibitors or angiotensin receptor blockers, long-acting calcium channel blockers like amlodipine, long-acting thiazide like diuretic like chlorthalidone or indapamide. If still blood pressure remains high, we should uh, add mineralocorticoid receptor antagonist such as spironolactone or amiloride or aplerenone. And if still the blood pressure remains uncontrolled with adding the MRA, we can opt for beta blockers with the vasodilation effects like carvedilol, bisoprolol, nebivolol, central alpha agonist like clonidine, doxazocin, or direct vasodilator like minoxidil hydrolazine can be added. In stage 4 or 5 of CKD, which we can combine thiazide with loop diuretic if needed. This diagram shows the management of resistant hypertensions. Initially, we use the first line agents like calcium channel blocker, thiazides, and angiotensin receptor blocker or ACE inhibitors. If the BP still remains high, we add MRA. If still BP is high, we can add alpha blocker, beta blocker, loop diuretic, or non-dihydrocalcium channel blocker. If still BP remains high, we can add central alpha 2 agonist or direct vasodilators. So, according to pathway second trial, in the fourth line treatment, it is recommended to include mineralocorticoid receptor agonist like spironolactone. National Institute of Health and Care Excellence advocates for using combination of angiotensin receptor inhibitors or calcium channel blockers, including long-acting thiazide for resistant hypertension. The fourth medication is natural this mineralocorticoid receptor blocker. If four drug scheme ambulatory BP remains under control, the fifth drug is added like beta blocker, central alpha 1 agonist, vasodilators, direct vasodilator. Eplerenone may be a substitute for spironolactone because it appears to have a superior safety record. In stage 4 and 5 CKD, thiazide diuretic can be administered in conjunction with loop diuretic. It has been believed that chlorthalidone is more effective than hydrochlorothiazide, especially when it comes to treating resistant hypertension. There are new and emerging drugs like finrenone. It is a non-steroidal MRA that lowers the BP modestly and protects the heart and kidney in diabetic and CKD. SGLT2 inhibitors, they lower the blood pressure, provide strong heart kidney protection. Baxdrostat block the aldosterone synthetase, reduces the aldosterone, lowering the BP in trials. Aprocitentan, aprocitentan, it is a dual endothelial blocker. It lowers the BP and protein in the urine. There is firibacetat. It acts on the brain's renin-angiotensin system, and it is a centrally acting APA inhibitors prodrug. Uh, we have sacubitril or valsartan combination, that is ARNI. It may help in resistant hypertension in future. In hypertension due to RAS activity, there is salt and water retention, vasoconstriction, sympathetic activation, CV, cardiovascular remodeling, and these changes contribute to resistant hypertension. Moreover, to the development of nocturnal hypertension and blunting of the normal nocturnal blood pressure dipping. Neprilysin inhibition prevents the degradation of these peptides, resulting in natriuresis, vasodilatations, and there is a reduced sympathetic tone, which lowers the blood pressure. In combination with RAS blockade, neprilysin inhibitors reduces the blood pressure. It reduces the arterial stiffness, cardiac hypertrophy, and fibrosis. This is the overall management of approach of a resistant hypertension, which I have already discussed. There are some device-based therapies like continuous positive airway pressure It is useful if the sleep apnea is the cause for hypertension. Baroreceptor activation shows mixed results, equivocal results. Central iliac artery venous anastomosis. Earlier studies showed good BP lowering. Renal sympathetic denervation. This is a newer ultrasound and catheter technique which shows sustained BP reduction. FDA approved the renal denervation in late 2023 for patients with uncontrolled BP despite medicine or who cannot tolerate them. So, a true resistant hypertension is uncommon. Many cases are due to poor adherence or white coat effect. Correct BP measurements and ambulatory blood pressure monitors are essential. We should use a structured treatment plan with lifestyle changes, optimal drug combination, and patient specific dosing. Newer drugs like SGLT2 inhibitors, ARNIs, finerenone, and device therapies like renal denervation are promising for the future. A good physician treats a disease, the great physician treats a patient who has the disease. It was uh, a good quote by Sir William Osler. With this, I conclude my today's topic. Thank you. Keep learning.